So after knowing this, let's see the protocol which was prescribed for the passive protocol also. That is, we have already seen that BFR, BFR has an important role, not only when exercise is there, passive BFR has also some role. We have already seen that. As far as preservation of the muscle mass loss is concerned, not for the potential exercise. And regarding the protocol which was given by the Peterson et al. In 2019 in their paper, you can see that for the BFR, for the passive BFR, the frequency can be 1 to 2 times per day, and the duration for it depends upon the bed rest or the immobilization duration. It may be 5 days, or it may be 1 week or so, and the restriction time is approximately 5 minutes. It is generally 5 minute interval. You are giving restriction for up to 5 minutes, and a type may be small and a large muscle group, whether it may be arms, legs, or unilateral or bilateral, and a set of 3 to 5 set, and cuff size, like we have already seen. Cup size maybe 5 centimeter, which is smaller. 10 to 12 maybe medium. For 17 to 18 it is large, but we always prefer a relatively larger cup size. And the race between sets, uh, for the pressure, it may be what you call 3 to 5 minutes, and the pressure, how much it is, it is not certain. Higher pressure may be required sometimes. For example, 70 to 100% of the AOP, there is a limb arterial occlusion pressure. It may be higher pressure may be required. You can use up to 70 to 100% of the AOP, and the rest interval may be 5 to 3 minutes, and the restriction time may be up to 5 minutes. And the continuous type of the BFR, we can give continuous for say 5 minutes, the restriction form. This is the important for the passive protocol, where you are basically not doing any kind of exercise, but simply by using this protocol. But one has to remember, protocol is not has to be followed like anything. The protocol has to be done in such a way that the protocol, you have to adapt the protocol based upon your requirement. Individuality has to be done. That is important. This just give a guideline. That's all. This just give a guideline, and the protocol, you have to apply the protocol in your day-to-day practice. So going into the different protocol, we have already seen the different protocol for aerobic, for resistance, as well as for the resting condition. But the one point which is very important is that we always prescribe the exercise based upon arterial occlusion pressure. That is what you call the limb arterial occlusion pressure at the resting level, resting limb arterial occlusion pressure. And for resting limb arterial occlusion pressure, one has to know how to calculate it. That is very, very important. Normally, what we have done is, we have already seen from the previous graph that BFR plus low load is more effective than low load program alone. That is, addition of the BFR has a positive role. But however, for a strength gain, we have already seen that for a strength gain, the heavier load is more superior as compared to the low load plus BFR. So for a heavier load, this what you call the BFR is not, low load BFR is not enough. You have to do a heavy load, that is depending upon the principle of the what you call the specificity. And but the good thing is, BFR can be used as a bridge therapy. It can be used as a bridge therapy to a heavier load, because some of the people, some of the candidates, they may not be able to lift heavy because of the musculoskeletal problem, because of the weakness, because of the old age, because of the various other conditions. Because BFR you will get the similar musculoskeletal as well as cardiovascular benefit as compared to the normal exercise. So it can form a bridge where you add on the low load exercise by doing BFR, and then improvement, after certain improvement, then you can add on the high intensity classical high intensity exercise for the gain in the strength. And the BFR can be applied to any muscle that can be targeted to any muscle group. But the most important point is, only not that particular target muscle, it has a systemic proximal effect also. And the load can be used at 20 to 30% of the 1RM. We are generally focusing the lower load with a high repetition, because we are using the low load. That's why we are using the high repetition. That high repetition means more than 15. Classic the classic regimen is always 30 repetition followed by 15 repetitions. 30, 15, 15, 15, with a rest interval of say 30 30-second or 60-second. Normally rest intervention, short rest intervention is given less than 1 minute because we want to have that metabolic effect. That's why. And the pressure is generally we apply the pressure relative to the arterial occlusion pressure during the resting. This we have already done. And based upon that, approximately we can use, like, say 50% of the AOP can be done for the upper body. Like for example, lower body, it can be up to 80%. All these things. But how to calculate this, what you call the AOP? This is very important. It has to be gold standard. You have to use what you call the Doppler based Doppler ultrasound, sound based Doppler probe. You can use, and for example, you apply the cuff, you apply the sphygmomanometer. It may be mercury, it may be aneroid, cuff, and you increase the pressure by applying the probe, and this probe can be used on a superficial artery in a, for example, radial artery for the upper limb. For lower limb, it can be posterior tibial artery. You apply that, and you hear the sound. When the blood is flowing, then you will be able to hear the sound in the Doppler sound-based Doppler probe. And but you keep on inflating. Then, however, at a particular point, when complete occlusion happens, then you will not be able to hear any sound. That point is the arterial occlusion pressure. You can still confirm that point by doing a pressure little bit above that particular point, and then lowering, and then again lowering. And when you lower it, then ultimately, when at the time of the arterial occlusion pressure just below it, you will be able to hear the sound again. That is, blood flow is resumption of blood flow happen. So you can still confirm this pressure by just going upward, and then complete occlusion, then go upward still further, and then reduce it. Then after and below this particular point, then you will be able to hear the sound. So approximately, confirmation of that particular pressure, you can do that, because that pressure is important, because based upon that pressure, you are going to prescribe the exercise. And that's why normally inflate to continuously inflate the cuff until no more sound is heard from the Doppler. Complete occlusion is there, and then gently reduce the pressure until first sound is heard. This is the 100% arterial occlusion. So you complete occlusion is there, no sound, then slightly reduce the sound. When the first sound is heard, at point you see the pressure from the, what you call, the sphygmomanometer, and you can see that is the pressure which you are going to use as a 100% AOP, and based upon that pressure you can prescribe different things. So this is the example which they have done. See, they have applied a cup to the proximal, because cup has to be applied more proximal. Distal, if you apply the cup to the distal, then the damage may happen to the nerve structure. So nerve may get damaged. That's why it's always better to have the proximal cup. See, they are doing for the upper limb, and the person here is by using the Doppler probe. He is basically hearing the sound by placing a Doppler from the radial artery, because that is more superficial. You can do in the brachial artery also, but generally radial artery is used. Like for example, for the lower limb, you can use in the popliteal artery also, but posterior tibial artery is more important, and it is more generally used because of the location superficially, and because of the more standardized protocol. Upper limb radial artery, lower limb posterior tibial artery. This is important. Similarly, for example, lying down also, you can measure. This is the cup. This should have been pressed a little bit more proximal, no problem. And here, by placing the, what you call, the Doppler ultrasound, sound-based Doppler ultrasound probe, you can hear the sound, and based upon the complete occlusion, you can measure the 100% AOP. So that is important. Another point, suppose what is happening is, if you don't have such kind of the instrument, then what will happen? Approximately, you can do based upon your systolic blood pressure, especially for the upper limb. For the upper limb, based upon the systolic blood pressure, you can you can calculate your what you call the occlusion pressure for the, especially for the upper limb, or you can use what you call for the approximate knowledge. You can still use what you call the simple pulse oximetry, because pulse oximetry, if complete occlusion is there, then what will happen? There will not be any pulse. So based upon that approximate rough guide, you can get by simply using a pulse oximetry also. Another point is, without using any kind of the occlusion pressure also, you can do, like for example, you can tie the cuff, and by having that subjective tightness feeling, it can be, say, up to from 1 to 10 score, up to 10 score, you can say up to the 7 or 8 or 6 to 7 or 6 to 8 tightness score you can do. That is a approximate guide, but the gold standard is always use of the Doppler probe. vascular ultrasound, vascular Doppler probe, and actually measuring the 100% AOP. That is the gold standard which one has to understand and one has to apply in their practice. Next one. Like we have already seen, there are different benefit of the blood flow resistance training. Like it can be used in rehabilitation, it can be used for reduction of the atrophy, it can be used for different chronic injury where you basically at the bridge therapy and less equipment is required because you just have to buy a cup, that's all. And if you don't have a vascular ultrasound, also you can use the other indirect methods like systolic blood pressure for upper limb or subjective feeling of that tightness score you can use. So all these things also, and it also used not only for the elite player, not only for the sedentary people, but also for the elite player, for astronauts also, for the immobilized patient, for the post-operative condition like ACL reconstruction. So blood flow restriction has a tremendous potential to use, and it is relatively similar also. So one has to understand the difference between the high intensity and blood flow, because based upon that you can judge whether a particular person is has a prone to a kind of side effect to BFR or not, whether you will be able to just the BFR is more suitable for this group of patient, this group of client or not, all these things. So for that you have to understand the basic physiology. Like for example, blood pressure. If you see the high intensity resistance training and the BFR, both will increase the blood pressure, no problem, both will increase the blood pressure. What about the stroke volume? Stroke volume will be decreased by BFR. So BFR will decrease the stroke volume. So if you are having problem in stroke volume, ejection fraction is very less. If you are having problem, then you should not use, you may not use, it is better to avoid blood flow resistance training, because in case of the high intensity exercise, stroke volume may relatively may be decreased, or it may remain the same, but BFR it will decrease. What about a nerve conduction velocity? BFR doesn't have any negative effect on a blood nerve conduction, because sometimes what is happening is if you tie the cuff too distally, then it may have the chance of a pressure, pressing and pressure, it may causes pressure injury to that particular nerve. But many study has done, and they have said that there is not much of the difference in nerve conduction velocity, but high intensity exercise, resistance exercise, there is increase in nerve conduction velocity maybe. Heart rate is increased both in BFR as well as the high intensity exercise. Muscle damage, BFR not so much there in case of the BFR, but if you combine BFR with a high intensity, then muscle damage will be there. More problem, more soreness will be there, more pain will be there, more DOMS will be there, also muscle soreness will be there. All this problem may be there if you combine. That's why BFR is always better to do low intensity. In case of the high intensity exercise, the basic mechanism is micro muscle damage because of that stimulation of the satellite cell and the growth is there. This is one of the mechanism for the growth we have already started. In case of the BFR, it is not so there. Maybe there, like we have already seen that the wavy pattern of the sarcomere, lengthening of the sarcomere, which are specific to the ultrastructural changes specific to the BFR, we have already seen in the previous slide. But muscle damage is not so much in case of the BFR. What about the fibrolytic activity? Fibrolytic activity is increased in case of the BFR as well as the high intensity. And coagulation profile, many of there is always risk of the having hypercoagulation if the patient is from hypercoagulability state, or if the patient has a history of the DVT, if the patient has a problem of what you call the varicosity of the vein, because of the incompetent valve of the vein, then it's always better to avoid BFR. But as such, normally in normal patient, the patient who are not having any high risk of the thrombosis, thromboembolic phenomena, then in those cases, the BFR has a similar coagulation activity as high intensity exercise. This is also important. Post-occlusion blood flow is increased in case of the BFR as well as the high intensity. There is increases there. That's why just by knowing the basic physiological comparison between high intensity as well as the BFR, you will be able to you judge whether a particular patient is or a patient subject is better for BFR, or whether you should avoid it or not. This is important. So going to the different this thing, like I have already told you regarding the application of the curve has to be as proximal as possible. Then only you will be able to target. Otherwise, if you do distally, then what will happen? There is always chance of having injury to the nerve. Nerve damage injury is always there. So I always avoid like that. And this is the various katsu training is very famous in Japan. They have been conducted like many things, and some of the complications they have reported, and we have to know what are the complications where they have like 3,000 katsu session per day is done in Japan for years. with no reported complication. So complication, the amount of the complication of Katsu training or blood flow resistance is relatively less. It is not very high. So you don't have to worry. But the thing is, you should have clear idea where to use, when to use, how much to use, and all these things. Basic physiological understanding has to be done, has to be there. Like for example, national survey in 2005, they have done a 6 DVT. Deep vein thrombosis case was reported in 12,642 people who are undergoing 32,000 Katsu session. That means 1 by 100, thousand in case of the general population. So this is a general population, and this is the hospitalized. So if you see the proportion, so Katsu training has a relatively lower cases of the deep vein thrombosis. This is the general, general what you call prevalence or proportion, which you can see the general population as well as hospital. Like for example, 1 by 10 in hospitalized patient, you may get a DVT. But in Katsu training, 6 DVT case was seen in 12,642 people, and they have undergone 32,000 Katsu session. 1 case of the pulmonary embolism, they have reported. 1 case of the rhabdomyolysis, they have reported in 32,000 session. And cautions and relative contraindication also you must important. Like for example, sickle cell disease or any kind of disease where exercise, you basically have contraindication for exercise. Your blood flow resistance training you should not also do. Like for example, children who are having less than 5, not much data is there. That's why it's always better to avoid. If you don't know anything, don't do it. If you don't know anything, that this is the golden standard. If you have any doubt, don't do it. Then fever, pregnancy, all these things, or near the fresh wound. If there is fresh wound, you don't apply the cuff. If there is a lymphedema, then don't apply the cuff. If the limb has any vascular problem like catheter or vascular access or indwelling catheter, it's don't apply it. If there is a pain, healing. If injuries healing is there, if there is lots of pain is there, don't apply the pressure. So you have to apply your common sense, and you have to apply your basic clinical reasoning in order to whether to use it or not, decide whether to use it or not to use it. This but as such, the complication, the side effects are very, very less. This is one has to understand. Similarly, this is the what you call the side effect, most frequent side effect profile, which was given during the Katsu training, and it was reported by Nakajima et al. In 2006. Here you can say subcutaneous hemorrhage was 13.1 percentage. They have reported. Numbness was also reported. Cerebral anemia they have reported. Cold filling, venous thrombosis 0.0. That is 0.055%, not even 1%. Pain was reported. Itching was also reported. Deterioration of the ischemic heart disease, they have reported in 0.0116. Feeling, sickness or feeling, subjective feeling of sickness, 0.016%. Increase of the blood pressure, 0.016. These are the different, what you call the side effect, most frequent side effect because of the Katsu training, which was reported. Similarly, same author, they have reported this side effect also, like subcutaneous hemorrhage was the total was the 1650 was reported. Hospital and clinic this much, and what you call different setup. These are the different rehabilitation or gym trainer, different center where in different center it was reported. Like for example, in case of the gym training gym, it was reported around 1105. Similarly, numbness, how cerebral edema, cold feeling, venous thrombosis 7, out of the total 7, 1 was reported in hospital and clinic, 3 was in this office, and 3 was reported here only. Pain was also itching, and what a deterioration of the what do you call the ischemic heart disease, deterioration of the ischemic heart disease, all these things, feeling of the sickness, and what do you call increasing of the blood pressure, physical awareness, dizziness, pulmonary embolism, rhabdomyolysis, palpitation, nose bleeding, deterioration of the diabetic retinopathy. Because in case of diabetic retinopathy, also we don't give, you don't prescribe the Valsalva whenever we don't high intensity exercise, especially with the breath holding resistant training. We don't give normally because of the fear of the detachment and all that stuff. And here also, it's always better to you have to understand where you have to avoid the blood flow. The fainting was reported in only 1 case. Fainting was reported. Cerebral infarction, only 1 case. Edema, hypoglycemia. So all these things are common side effects which were reported. But the point is, the major complications are very, very rare. This is good effect. And the what you call the Motohiro Yasuda et al. 2017, they have reported, the blood flow resistance training has been used for different improvement. Improvement was there. Like for example, it was for muscle hypertrophy. This facilities was used for muscle hypertrophy, for muscle strength gain, weight loss, beautiful like slimming, paralysis improvement, pain improvement. For pain improvement also, BFR is used also for pain improvement. Stiff shoulder improvement, low back pain improvement, reducing depression syndrome, because we already seen that BFR has a systemic effect, or a neuro improvement was there, and other diseases. All these things was basically used for BFR, and out of this thing, what they have reported, these are the side effects which they have reported. Like for example, cold feeling they have reported in these facilities, numbness, subcutaneous hemorrhage was the maximum, and anemia was also the maximum reported in various number of the facilities. Drowsiness, pain, nausea may be there, itching may be there, hypertension relatively less, headache may be there, other may be there. These are the important what they have done 232 facilities in Japan. They have studied 12,827 subjects, and out of his 30.10 are females, where males, whereas 69.90 are females, and they have done from November to December 2016. So these are the basically things. Another important point is some of the author, like for example, this author in 2018, they have reported 3 cases of the syncope or pre-syncope episode among 21 healthy people, out of whom 9 were the females, males. 9 males, 21 healthy people. They during the BFR familiarized, during the session, during the familiarization, where they have been undergoing BFR for the first time, because maybe a 3 syncope or pre-syncope episode was reported. So that may be because of the what you call neurogenic or syncope. Maybe they're not because of the cardiovascular, but because of the neurogenic syncope maybe. And BFR was given basically with low load resistance training or low intensity neuromuscular electrical stimulation they have given. And during the episode, during the actual exercise therapy session, no syncope was recorded by the author, but it was recorded during that's why familiarization is important. Caution and familiarization has to be there always. A close watch has to be there during and after the BFR. This is important. That's why you can even do the PAR Q or PAR Q plus questionnaire, like physical activity readiness questionnaire and other screening method we use for general exercise prescription for the starting of the general exercise program. You can it's always better to do for BFR also. This is important. So this is the basic treatment information which you want to get before doing the BFR. Just like any other exercise therapy, you can get this information. This will be beneficial if you get the information. Like for example, before doing anything, you inquire about a subjective symptom like chest pain, chest discomfort, palpitation, soreness, pain is there or not. If it is there, then it is always better to do exercise tolerance testing. Or if there is a spondylosis or joint pain and symptoms there, then you go to the sports medicine or orthopedic examination or guidance or referral is important. You do history, like if there is a history of the cardiovascular system, then it's always better to do exercise tolerance test. If there is an orthopedic problem, then always refer to an orthopedician or a sports medicine specialist. And or if there is a existing of any lifestyle disease, like it may be hypertension, diabetes, hyperlipidemia, obesity, it's always better to assess the severity, and depending upon the severity you may or may not do exercise tolerance test depending upon their requirement. So this decision you have to take. For example, family history, if there's a positive family history, myocardial infarction, sudden death in the first degree relative, a family history of the relatively young sufferer, such as a father or a first degree male relative less than 55, male relative less than 55 for mother, or the female relative, it has to be under 65 who have undergone myocardial infarction or coronary revascularization or died suddenly. In this, that is the positive family history. In that case, it is always better to do a close examination or exercise tolerance test. Maybe then lifestyle, habit, diet, and smoking, all these things is always better to do. Inquire whether smoking is there or not, whether any claudication is present or not, whether any problem of the vascular problem is there or not, alcohol and all these things. It's always better to do inquire, and lifestyle guidance may be done. And it is always to do a ECG also. It's always better. Suppose if you detect a myocardial infarction, then always refer to a cardiologist or a sports medicine specialist or a sports cardiologist, or you can do what you call an exercise tolerance test is recommended also. ST segment abnormality, it may be ischemia side, or it may be frank infarction, it may be delay, it may be ST elevation or ST depression, it may be horizontal depression, or down sloping depression is more important, horizontal and down sloping is more important. So all these things you can detect during the resting. Then it's always better to do exercise tolerant test. During the exercise tolerant test, whether you see whether if there is any ST segment changes or not, ventricular arrhythmia is there or not. If there's, it's always better to avoid it, because during the BFR sympathetic stimulation will be there, which may predispose to have the arrhythmia. That's why it is important. Other important observation, any kind of the important observation, is always to do exercise tolerance test, or even if you are not doing exercise tolerance test, it's always to do a comprehensive pre-participation physical examination, as well as focusing on the cardiovascular, heart and other stuff with a multidisciplinary approach. This is the key method. That's why it's always better to do in a multidisciplinary setup. And if you don't know the status, the clinical setup of a person, it's always better to avoid such type of the training. BFR, it's always better to avoid. And if you have to do it for a very less duration, a very low load, very low occlusion pressure. That's all. So this which you have to understand. And some of the contraindication and the indication also, it's always better to remember. Like for example, this was given, like here, if there is a high blood pressure of say 140 to 159, of systolic blood pressure 90 to 94 millimeter of mercury, then depending upon whether requirement, you may give still blood flow resistance training. You can it is indicated you can give, for example, if the conditional indication of blood flow is there, if systolic is 160 to 179 or 95 to 99 millimeter mercury diastolic, or if the man is more than 40 years or female more than 50 years, that are in treatment or who do not have any contraindication, all these exercise tolerant tests, so you can give depending upon your requirement. That is conditional indication of the blood flow is there. But however, if the systolic blood pressure is more than equal to more than 180 millimeter mercury, or if it is more than 100 millimeter mercury diastolic, or if the what you call the cardiothoracic ratio of more than 55%, like indication of the cardiomegaly and all that stuff is visible on the chest X-ray or chest röntgogram, genogram, or life-threatening arrhythmia is there, or ischemic changes is shown by the ECG, that is electrocardiogram, excluding time when safety was confirmed by an exercise tolerance test. A uric protein of, let's say, how much, 100 millimeter of mercury, or a hypertensive changes in the fundus. If you see the fundus and if you see all these changes, then it is always better to avoid blood flow. You just avoid any kind of the blood flow resistance training. For example, for diabetes also, in case if the diabetic person there, then the fasting, if the fasting blood sugar is say 110 to 139 millimeter mercury, you can do blood flow, no problem. But if it is say 140 to 200 249 milligram milligram per deciliter, then for the men who is more than 40 years, female more than 50 years, that are in treatment and who do not have contraindication, then in that case you can use, even if you have fasting blood sugar. If you have very high fasting blood sugar, like for example it is 250 or more than 250, and ketone is present, urinary ketone is present, then it is always better to do any kind of exercise. You just avoid any kind, not only blood flow, but any kind of exercise. And diabetic retinopathy also is always better to avoid resistance exercise, high intensity resistance exercise, and also blood flow resistance training with low intensity, always better to avoid. In case of the hyperlipidemia, for example, if you have the triglyceride and total cholesterol and triglyceride this much, then no problem. If your total cholesterol is 250 or minimum, or say triglyceride 300 or more, then depending upon your condition, like you can undergo this blood flow resistance training. If suppose if possible, exercise stress test can also be given, and depending on that you can give the blood flow resistance training. For example, obesity, in case of the say 24 to 29 kg per meter square for obesity BMI, then no problem, you go ahead, no problem. But if you are obese, like for example if you are more than say 30 or more, then it's always better to avoid blood flow resistance training, because obesity has multiple problems. You have to apply more pressure, because because of the fat mass, the occlusion pressure has to be higher. Then there is always risk of the venous thrombosis also in case of the obesity, plus other abnormality, because obesity are always accompanied with other comorbidity like hypertension, like diabetes. So you have to understand, and it's always better to avoid blood flow resistance training when your BMI is more equal to or more than 30 kg per meter square. For less than like 24 to 38, and for in case of the lower limb joint, there is a lower limb joint damage because of like OA, osteoarthritis, knee, then it's always better to have the orthopedic examination, and the exercise restriction can be done depending upon the different requirement. So this is the general principle. And another principle also, different author has also given, like for example, this is a simple for apparently healthy person going BFR. This you can see whether, for example, whether you have to undergo or not. Like suppose in presence of any item in the BFR should be avoided. What are the items? Self-reported easy bruising, because bruising is common in case of the BFR. If bruising is, it may be because of the platelet abnormality, it may be because of the vitamin C deficiency, it may be because of many other factors. So it's always better if there's any kind of the acute systemic illness. Acute systemic illness has to be controlled first. You cannot, it's always better to avoid blood flow resistant training. A medical history, a medical problem that physician have belief may be life threatening. It is enough. Belief is enough, because it's always better in case of any kind of doubt. It's always better to stop it. If it is always better to not to go ahead. This is important. So if in case of doubt, it's always better to do it. For apparently healthy individual with less than 2, that is, these are the two factor, factor BFR may be considered safe. That is less than 2, that is low cardiovascular. In case of the low cardiovascular risk, then BFR can be done. Like for example, these are the different risk factor which they have given. Like for example, for a male, cardiovascular risk is how they have calculated: equal to more than 55 for male, female equal to more than 65 years, history of the premature cardiovascular death in case of the first degree relative, male less than 55 years old or female less than 65 years old, with what you call premature death, in their first degree related, smoking, dyslipidemia, total cholesterol is more than 190 milligram per deciliter, or LDL cholesterol more than 115, HDL less than 40 in male, and less than 46 in case of the female. And see, all these things are based upon different guidelines, but one has to understand also the cholesterol paradox. Cholesterol, and especially the LDL cholesterol. Triglyceride is more dangerous, which one has to understand. So this guideline can be changed, modified depending upon the recent information about the cholesterol. Because the inverse, the mortality and the cholesterol, especially total cholesterol, may not be always proportional. This also one has to understand based upon the recent insulin resistance. If the insulin resistance, always you have to grade your cardiovascular risk. Fasting blood sugar between this and this, oral glucose tolerance indicating of the insulin resistance. And the most of the time, insulin resistance, the most important aspect of the insulin resistance is focusing on the level of insulin rather than focusing on the glucose. Instead of focusing on the level of the glucose, you focus on the level of insulin. Fasting insulin level, you just do fasting insulin level, and based upon the fasting insulin level, you can predict whether you are having insulin resistance or not. Or you can do HOMA IR also, HOMA IR and other indirect measure of the insulin resistance. Then glycated hemoglobin is also important. HbA1c in case of diabetic and all that stuff. Obviously, we have already seen equal to more than 30 kg per meter square. Then risk factor is there. It's always better to avoid BFR with circumference of equal to more than 102 centimeter for men, and equal to more than 88 centimeter for female. So these are the different risk factor for cardiovascular system, and depending upon that, if it is less than 2, then you can do BFR. Otherwise, it's always better to avoid BFR. Is important. So before going into the BFR, it's always better to have a decision making whether you have to include a particular patient for BFR training or you have to exclude. This is the final set clinical decision for exclusion and exclusion BFR, as it was given by the author, this author in 2021, Rolex et al. Here they have seen that for any kind of the loading problem, only the person is not able to lift a very high load. That is loading problem because of the various skeletal-muscular problem. It may be because of the injury. It may be because of the old age. Anything. It may be because of that. Then you can prescribe BFR for that. For a pain problem also, BFR has been used for reduction of the pain, as we have already seen in case of the Japanese the indication. Then you can include all those patients who have this loading problem, who have this pain problem. Because of the pain problem, they are not able to do high load exercise. All these things you can include in case of the BFR. But after that, you have to see the clotting consideration. there is some risk, there is theoretical, there is possibility of thromboembolic phenomena. Clotting, DVT, is always there in case of the BFR. So it's always better to see whether there is clotting factor or not, or possibility risk factor is there or not. You always better to study. And also it's always better to see whether hemodynamic consideration, you have to, whether they are hypertensive or not, whether stroke, how much is a stroke about us, because we already know BFR will increase the heart rate, BFR will increase the systolic blood pressure, BFR will decrease the what you call stroke volume. Patient may faint also, syncope may also be happen. So this thing you have to see. Physical activity consideration, you have to see whether the particular person prior to BFR, whether they are physically active or not, because excessive physical activity will causes rhabdomyolysis, creatine kinase will rise like anything. Then it will ultimately lead to the acute liver kidney failure. So all these things you have to consider. So BFR, before consideration of BFR, it's always better to see how much physically active they before starting the exercise, and how much you have to give. All these considerations you have to see. And is there is any additional medical history related to tourniquets use, whether petechial hemorrhage, are easy, bruising and all that stuff, any kind of the contraindication to exercise, any kind of anything which you have to gather the information. And it's always better to consult the physician, treating physician. It is always better to consult your friends. It may be orthopedician, it may be cardiologist, it may be rheumatologist, it may be sports and exercise medicine specialist, it may be clinical exercise physiologist, it may be anyone, clinician. You have to take into consideration, and whole decision you have to take depending upon all this input. That's why BFR is important. You cannot just prescribe BFR like anything. There is always potential for damage is always there. So like, for example, this is the guide which they have given. Here you can see that, like, for example, thrombophilia. If thrombophilia is not, if suppose thrombophilia is present, then hypercoagulability is there or not. If the hypercoagulability is always better to avoid BFR. Don't do BFR until the physician clears. If suppose hypercoagulation is not there, then is there any history of clotting? If history of clotting is there, then medical consult has to be done, because after medical consultation, whether anticoagulant was given or not, if the anticoagulation was not given, then you have to adjust whether hypercoagulability is not, or is not. Suppose it is not present and history of the clotting is not present, then you can give BFR. You can give BFR, no problem, depending upon what you call under the supervision. But if everything is present, if the history, always is better to do medical consultation. And if anticoagulation is there, then you have to consult your medical team, the treating physician you have to consult. And depending upon the treating physician, then you can use. Okay. So all these things you have to understand. So just by knowing all these things, because the coagulation profile is important. There, even if there is a minute risk for thromboembolism, then you have to avoid BFR. That's why you can use different risk factor calculator can also be used. So that's why whether presence of the hypercoagulability present or not, this is also important. History of clotting factor, whether it was present or not, you have to see. For example, if coagulation is not present, even if thrombophilia is present, then what you call and history of clotting is not present, then generally risk is low. Then you must has to discuss with the patient whether you should go ahead with the BFR or not, because thrombophilia, because many of the thrombophilic cases are hereditary also, and there is always better to screen it. Then for example, here we have seen that the hypercoagulability, if thrombophilia is absent, there is no thrombophilia, then you see whether hypercoagulability is present or not. If it is present, then anticoagulation therapy is given or not. Then always better to consult the medicine team, because risk is always there. And you have to discuss with the patient risk and benefit ratio. And if the coagulation is not present, history is not present, then you can go ahead. If no symptoms of clotting, if there is no symptoms of clotting, sign and symptoms of clotting is there, then BFR can be given. So So all these things you can study you can apply this flowchart, you can apply in case of the thrombophilia, in thrombophilia is present. For example, in case of the general people, in case of the general public, you can always use this point system in order to see whether there is high risk of the thrombosis or not. Like for example, using high risk in the determination of Kaju training. For example, 0.5 is given for history of deep vein thrombosis. If there is a history of deep vein thrombosis, absolutely don't use the BFR. So for 0.4 and 5, it's always better to avoid BFR, especially for 0.5, like deep vein thrombosis, hereditary thrombotic tendency, anti-phospholipid antibody syndrome, all these things. It's bad. Don't use BFR. In case of the pregnant woman, especially in the later phase of the pregnant, it's 0.4. It's always better to avoid BFR. It's always better to avoid BFR. 0.3, you have to see whether risks and benefit. Like for example, varicosity of the vein. It's always better to avoid BFR. Even if you have to use it, you have to be very careful. Or prolonged immobilization. If there is a prolonged immobilization, like for example, incapable of 8-hour thromboprophylaxis rehabilitation. So prolonged, if there is a prolonged, very long prolonged immobilization, is there's always risk of the thromboembolic phenomena is there. Like other is the atrial fibrillation, heart failure. Then there is always risk of the thrombosis also there. So this all comes under 0.3. For 0.3, you have to see whether you have to see whether there is a risk benefit ratio. It's always better to avoid. Otherwise, you have to take caution and has to be very, very careful. The 0.2 is given for the person who are more than 80 years. More than 80 years, that is, aged people has a higher chances of the thrombosis. BMI, if the BMI is equal to more than 30 kg per meter square, like we have already seen. In case of the obese people, there is risk of the thrombosis, hyperlipidemia, malignancy. Using lower limb tourniquet, it's always better to avoid lower limb tourniquet. Using oral contraceptive, adrenocortical steroid, quadriplegia, those who are quadriplegia, or high hemoglobin, because of hemoglobin high, there's always chance of the thrombosis. So all these things are possibility of thrombosis. 0.2 is given, and 0.1 is for age between say 40 to 58. 40 to 58 years of age, women, or BMI is 25, between 25 to 30, then 0.1 is given. So the point to remember is to have a 0.5, avoid it. Don't do BFR. If 0.4, it's always better to avoid. 0.3, you have to see whether it's of benefit ratio. Even if you have to do it, you have to be very, very careful. This one has to. So the rule of thumb is avoid high intensity load. Avoid overload with BFR. Number one. Number two, don't do BFR for a very long time. Never do it. Avoid hemostasis with a tourniquet, especially for a lower limb tourniquet. If hemostasis is there, then there is chances of deep vein thrombosis is there. And if deep vein thrombosis is there, then there is a pulmonary embolism, and sudden death, and all this stuff will be there. So it's always better to avoid hemostasis with a tourniquet. And one has to be very, very careful for contraindication. Like for example, and one has to follow this process. Like for example, for a thrombophilia case, you have to follow this process. So after knowing this point, we have to understand that what you call the risk of the thrombosis is always there. So one has to be very, very careful. Suppose suppose if there is, because in case of the thrombophilia, then thrombophilia has a very high risk of the hypercoagulability, and the thrombotic risk is there. So one has to follow this flow chart can be followed. It was given by Rolik et al. In 2021. Here you can see that because thrombophilia, many of the thrombophilia are hereditary condition of the thrombophilia. So one has to be very careful whether you have to use BFR or whether you don't want to use BFR and all these things. Like for example, if thrombophilia is there, then you see whether hypercoagulability is there or not. If hypercoagulability is there, then no BFR until the physician clear. You have to be in touch with a treating physician. You have to be in touch with the exercise and sports and exercise medicine specialist. You have to be in touch with the clinical exercise physiologist and or many other physicians. And after that, you have to take a collective decision based upon risk benefit ratio. So if thrombophilia is present, hypercoagulability is absent, then you can see whether there was history of clotting or not. If history of clotting is not there, then risk is low, and then you can discuss with the patient whether they want to still have the BFR session or not. If the history of clotting is present, then you have to consult the medical team. You have to inform the medical team whether what can be done, whether you have to you have to start the anticoagulation or not. All these things, your medical team is the one who can give the guidelines. If the thrombophilia is not present and hypercoagulability is present. If the hypercoagulability is present, then you can consider, if suppose if anticoagulant medication is not going on, then still you have to consult the medical team whether you want to go ahead with the BFR or not, depending upon their collective decision. You have to go. And if anticoagulation therapy medication is present, and although it is as a low risk, because anticoagulation therapy is already going on, but still you have to consult the medical team, because they are the one, and collective decision has to be taken based upon the risk benefit ratio. And if hypercoagulability is not present, then again you have to see whether there was no any history of clotting or not. If the history of clotting is present, and if anticoagulation therapy or medicine is going on, then you have to consult the medicine, and you can start a BFR, talk with the patient, because the risk may be a little bit lower. And if there is no history of the clotting, no history of the coagulability, no history of the thrombophilia, then BFR can be started if there is no sign and symptoms of the risk. So if no sign and symptom of risk is there, that BFR can be started. So based upon this, the information, based upon this guideline, you can do whether you have to do whether BFR or not. But one point which one has to remember: if you don't know the current status of the client or patient, and if you have any kind of the even small amount of doubt, don't do it. It's always better to avoid it, avoid doing. And instead of the doing, you have to focus on, you have to focus on what you call the different other speciality. You have to take the opinion of the other physician, and collectively, and you have to discuss with the patient also, and depending upon the ultimate risk benefit ratio, you have to decide. But the point one has to remember is always avoid high intensity exercise with BFR. Avoid overloading. This is not important. BFR is meant for low load. That's all. Low load intensity exercise plus BFR. If you do BFR with high intensity, then there will be problem. Avoid doing for a longer duration. Avoid it. You don't have to do for a longer duration. And avoid having hemostasis with a tourniquet, especially for a lower limb tourniquet. You have to avoid. You have to avoid using what you call the lower limb tourniquet, and especially for hemostasis, because there's always chance for the deep vein thrombosis and all these things. And you always have to be careful about the contraindication, and you always have and everything has to be closely monitored. That is very important. So this point, this flows out another thing you have to keep in mind, and you have to be very, very careful in doing any kind of the BFR in case of the clinical patients, clinical condition, or the patient who is having some kind of the risk factor, or the patient where the clinical condition or the risk factor you don't know at all. That is important. If you don't know anything about the patient, avoid it. So same thing, going again to different, this thing has been given by different thing. I will not go into detail of all this thing, but the important is BFR. This is a summary concern about the BFR with DVT developing medically compromised population, because you have to do prescribe exercise to various patients also, not only for healthy population. So you have to see, there are so many concerns of the BFR and DVT in those patients. Like for example, hypertension. Patient with hypertension, they are already in a state of hypercoagulability state. There is the potential pro-thrombotic state is there. The increased thrombotic risk has a primarily attributed to the endothelial dysfunction associated with the hypertension, because of the endothelial dysfunction. There is already there. So if you have to be very, very careful before using BFR, especially with a prolonged time of high load. Additionally, hypertension frequently present with elevation in the hemostatic factors such as selectin, platelet aggregator, fibrinogen, PAI1. So all this thing is important in case of that. So this basic medical information you have to know. Like for example, post COVID-19 infection, COVID-19, one has to understand patient with the COVID-19 may develop vein and arterial coagulopathy caused by endothelitis. Endothelial dysfunction is there, inflammation of the endothelium. Because see, COVID-19 is a what you call inflammatory thromboembolic immunoinflammatory condition. So thromboembolic hypercoagulability condition is always there. So one has to be very, very careful. Similarly, for pregnancy, postpartum women also, it is a diabetes also. You have to be very careful for type 1 and type 2 diabetes. They are always in risk of the deep vein thrombosis because of the various systemic as well as endothelial dysfunction. One has to understand. In fact, for the hyperglycemia also, hyperglycemia itself can cause problem. Hyperglycemia triggered vascular damage by imbalance between nitric oxide and reactive oxygen species. Nitric oxide is what we call important for vascular vasodilation. and reactive oxygen species is damaging. So, and a platelet aggregation inflammation, increase expression of the coagulation factor like the hyperglycemia can causes persistent hyperglycemia or hyperglycemic spike. Frequent spike may causes endothelial dysfunction and hypercoagulative state. Post surgery, we already know that post surgery the vein thrombosis is there in case of the anabolic steroid user. So, for example, in case of the player who are anabolic steroid user or ergogenic aid, this is also important, especially for a player. One has to understand user because of the high risk of the thrombotic complications, cardiomyopathy, stroke, pulmonary embolism, fatal and non-fatal arrhythmia, myocardial infarction. Anabolic steroid user have a side effects such as dyslipidemia, polycythemia, hyperhomocystinuria, hypercoagulability state, cardiac and vascular hypertrophy, impaired angiogenesis, redox imbalance, redox imbalance is there, cardiomyocyte apoptosis. So all these things are there in case of the anabolic steroid user. And if you have to use blood flow resistance training for anabolic, you have to be very careful. So depending upon whether hypertensive, whether post-COVID, post-pregnancy, postpartum women, diabetes, rheumatoid arthritis, and chronic kidney disease, post-surgery, anabolic steroid users, you have to understand there are certain risks, and depending upon the risk benefit ratio, you have to adjust your exercise prescription. This is important. Another one, similarly for the thrombosis also, like we have, why I am focusing on thrombosis is very important because many of the perceived fear of the thrombosis always there in case of the BFR, and especially after the COVID-19, the fear of the thrombosis leading to thromboembolic phenomena, leading to stroke, cerebrovascular attack or cardiovascular attack like MI, myocardial infarction, coronary heart disease, all this problem. That's why, or sudden death because of the pulmonary embolism. So all these things one has to be remember. One has to. That's why thrombotic risk assessment is absolutely important if you have to give the what you call blood flow resistance. Like for example, this is the one which was given by this author in 2022. This is a risk factor like for example pulmonary embolism, abnormal pulmonary function, acute myocardial infarction, age between 41 to 59. All these things carry one point. You have to keep on point, and depending upon a different score, you can see whether have a low risk, moderate risk, high risk, or highest risk. For example, if 5 or more score, then it is highest risk. There is a 40 to 80% chance, and risk of mortality 1 to 5% incidence of DVT. So all these things point. So BMI, like for example, more than 25 to 39, major surgery, malignancy, BMI more than 40, there's 2 point, they carry 2 point. Then 3 point, this if S is more than 75, 3 point. Then if there is any acquired congenital thrombophilia, then 3 point, history of DVT, pulmonary embolism, all this important. Then acute spinal injury, if there is paralysis, 5 point, this carry 5 point, hip, pelvis, or leg fracture, stroke, multiple trauma. For women, if in case of the woman, history of the unexplained stillborn infant, this may indicate to what we call the phospholipid syndrome. This because of this thing, this what's called this one, antiphospholipid antibody syndrome. Antiphospholipid and antibody syndrome will causes all this unexplained stillborn infant recurrent abortion. These are the basically sign of that particular disease. Then oral contraceptive hormonal therapy, pregnancy, postpartum, postpartum up to 1 month or less than 1 month. So depending upon a different point, you can actually see whether your client is at high risk or low risk. This is important. Another point, this thing is also given by the author, the same author, regarding the risk of, they have modified, improved risk score, where they have a score different condition like previous VTE, venous thromboembolism case 3 score is there. There is a non-thrombophilia. If there is a no thrombophilia, then 2 risks. Current, lower leg paralysis or paresis, to prior, if there is any cancer, it may be, the cancer may be excluding known melanoma skin cancer present at any time in the last 5 years. Okay, let me 2 point ICU or CCU stay, intensive care or cardiac care unit 1, and there is a complete immobilization of more than, even if the complete immobilization more than 1 day, that's why complete immobilization is not good at all. if you are completely immobilization for at least more than equal to 1, then the risk is 1. You have to score 1. Then for as more than equal to more than 61 1. So if you have to add on this, and if the score is equal to more than 4, it is high risk. Don't do it. Don't do BFR. If it is moderate, 2 to 3 point moderate risk, 0 to 1 point low risk, you can perform BFR under supervision. So this is the scoring system for thrombotic. It is also important. Another important for just like I've already focused regarding the thrombosis, for diabetes patient also you have to, these are a different parameter for diabetes. I will not go into the detail, but this is also freely available, where you can see what are the relevant risk factors for diabetic. If you want to prescribe blood flow resistance training for diabetics, these are the different point. Like the patient with diabetic without any organ damage, or with diabetic equal to more than 10 years, whether it is or not. Type 1 diabetic mellitus for very long, more than 20 years, premature, all these things you have to see whether it is a high risk or not. This is important. This for cardiovascular, and for hypertensive individual also, before doing blood flow resistance training, is always better to see what are the risk factors. Like for example, if there is a present acute myocarditis is not present or not, especially after the post-COVID myocarditis. Many people are suspecting the COVID one, acute systemic, if there is illness or not, angina or ischemic ST, depression at a workload of less than 6 metabolic equivalent of tasks. If doing less than 6 MET work, metabolic equivalent of tasks, then you are having ST changes, then it is not so good. You have to see whether it is not. Then angiotomography of the coronary artery with the presence of the plug. All these things, with stroke and angina. So all these things you have to keep in mind before prescribing BFR to a cardiovascular patient, or hypertensive patient. Similarly, for rheumatoid arthritis patient, you have to understand whether they have what you call unstable angina, whether they have ECG alteration at rest or during any effort or any exercise, recent myocardial infarction less than 3 months is there or not, type 3 or type 4 heart failure, uncontrolled dysrhythmia or dysrhythmia is there, severe pulmonary hypertension, severe and or a symptomatic valve disease, aortic valve stenosis, aortic aneurysm, Raynaud phenomenon, acute endocarditis, pericarditis, all these things you have to understand. Or the prednisolone, you have used a prednisolone more, say a dose of more than 5 grams per day over past 3 months. So all these things carry the risk, which you have to understand. Like for example, systolic blood pressure equal to more than 160 millimeter mercury, and or diastolic or equal to more than 10 millimeter mercury prior to exercise, uncontrolled hypertension of is there more than 180 by 110 millimeter mercury. So all these things you have to understand, you have to keep in mind, and these are freely available, and before undergoing any kind of the BFR training. And for COVID also, we have already understand, because the thing is, COVID is a disease which has a very high chance of the thromboembolic complication is there. There are several laboratory abnormality associated with the COVID-19, including the thromboembolic complication. And alveolar capillary microthrombi formation, they are 9 times more prevalent in case of the COVID patient as compared to the influenza patient. This one has to know. There is endothelial damage already present, harmful effect of many different multi-organ damage is already there in case of the COVID-19, severe COVID-19 patient. Pro-inflammatory state, COVID-19 is inflammatory, pro-inflammatory with the risk of the elevated clotting factor. They are there for risk of the, deep vein thrombosis is very high. There may be comorbidity associated with the COVID-19, because of most of the complication associated with COVID-19, they are because of the comorbidity. It may be hypertension, diabetes, cardiovascular disease. So all these things is present. That's why before doing any kind of the blood flow resistance training, you have to check. In case of the post-COVID patient, you have to understand all these things. You have to follow all the risk assessment, like we have already discussed earlier. But the point is, more study is always required, especially in case of the COVID-19. And the assessment of the COVID-19, one has to understand, different this risk factor. One has to understand, like for example, this is severity. You have to understand whether he or she was admitted to the hospital or not. This is severity one, or not admitted to hospital but unable to resume normal activity, admitted to hospital but not require supplementary oxygen, admitted to hospital but require supplementary oxygen, admitted to hospital, admitted to requiring high flow nasal cannula, non-invasive mechanical ventilation or both, admitted to hospital with extracorporeal membrane oxygenation or invasive what you call mechanical ventilation. So all this disease severity, grading of the disease severity of the COVID-19 is important because disease severity is directly proportional to the complication. And this an inflammatory marker, if it is available, it's always better to assess inflammatory marker, like for example like ESR, C-reactive protein, high sensitive CRP, C-reactive ferritin, IL-6, lactate dehydrogenase. All these things is always better to have. Coagulation indices, coagulation profile, elevated D-dimer or fibrinogen, prolong prothrombin time, partial thromboplastin time. All these things it's always better to have. Consider if the patient used whether the patient was given any thromboprophylaxis or not post hospitalization, whether they have given epixaben or rivaroxaban or what do you call any other medication, whether heparin was used during the hospital, or low molecular weight heparin was used or not. So depending upon whether the patient used prophylaxis post hospitalization, particularly those with a history of the clinical illness. So you have to consider this thing, and depending upon the risk factor, you have to modify. You have to better avoid the BFR training, or even if you have to give BFR, then you have to be very, very cautious. You have to be very, very careful, and you have to modify the BFR such that less load is given to the system. This is important. So, so just after understanding all this pathway, different flow chart you can easily follow. This is a simplified flow chart for practical implication of the blood fluorescence training for whether for a clinical purpose, whether it's for a healthy or athletic purpose. After knowing all the all this, what you call the condition which you have to keep in mind. So this is a simplified flow chart for a practical implementation of the BFR for clinical as well as healthy patient as well as the athletic population. It was given by the Brenda R. Scott et al. In 2014 India. And you can see that does the individual have any contraindication for BFR? Contraindication, lots of contraindication we have discussed. If there is no contraindication, then you have to see whether the particular person is mobile or not. If he is mobile, then another point is you have to see whether he is able to do low load resistant training, that is 20 to 40 RM. If he is able to do low load resistant training, then you can what you call the combined low load resistant training with BFR if he is able to do. And again, you can add on, you can ask the particular subject whether he or she is able to tolerate the high load resistant training. High load resistant training, because we already seen that the classic high load resistant training is especially important as far as strength gain is concerned. So if they are able to tolerate it, then always combine the traditional high load resistant training along with the low load BFR, because low load plus BFR is superior than low load without BFR. But for strength gain, high load resistant training is superior as compared to low load plus BFR. That's why you want to combine the traditional high load resistant training with low load BFR if the particular person is able to tolerate high load. If the particular person is not able to tolerate the high load, then you have to, there is no other way. The BFR has to act as a bridge therapy. You have to combine low load resistant training with the BFR. And if the person is not able to do a low load like 20 to 40% of one RM, even 20 to 40% of the one RM, he is not able to do it, then focus on the low load aerobic type activity like cycling and walking. So you can combine the low load cycling and walking exercise with BFR. So low load cycling and walking, you can combine with BFR. If the particular person is not mobile at all, he is not able to do anything, then you can simply do BFR, passive BFR without any kind of the exercise. You can apply moderate BFR alone to the particular limb, that is without any exercise, only BFR, that is passive BFR. Because we already seen that the passive BFR also has some benefit like preservation of the muscle mass. Or what you can do is you can combine passive BFR plus neuromuscular electrical stimulation, NMES. Like we have already seen that neuromuscular electrical stimulation, there is the gain in the strength as well as the gain in the muscle mass is higher as compared to the NEMS, that is neuromuscular electrical stimulation without BFR. And so you can do passive BFR, or you can do BFR plus NEMS, that is neuromuscular electrical stimulation. If there is contraindication for BFR, how you are going to do it? It is very important. You have to understand if BFR is contraindicated, then you have to consult the treating physician. You should have a board of the consisting of the various various specialists of that particular specialty, whether it may be cardiologist, whether it may be neurologist, whether it may be an orthopedician, whether it may be sports and exercise medicine specialist, whether it may be a clinical exercise physiologist. All these things you have to consult, and depending upon the risk benefit ratio and all that stuff, BFR may be approved. If BFR is approved, then depending upon whether the patient is mobile or not, depending upon whether they are able to do low load resistance training, or whether they are able to do high load, so your decision can be changed. But if the treating physician and all the contraindication is there, and if BFR is not approved, then don't do it. Don't do it. If BFR is not approved, and BFR strategy may not be appropriate for this particular individual, and you have to talk with the individual. You have to explain everything, the risk and the benefit ratio, all the risks involved, all the problem, and that for that particular individual, BFR is not recommended at all. So this is a simplified, very simple flow chart given by the Brenda R. Scott et al. In 2014. And by using this practical flow chart, you may be able to do in your practice session whether you have to use BFR or not, whether you have, and which type of BFR you have to use, whether you have to use BFR with what you call a passive BFR without any exercise, or BFR plus neuromuscular electrical stimulation, or BFR with low load aerobic activity like cycling or walking, or BFR with low load, say 20 to 40% of 1 RM, what you call resistance training, or BFR with low load BFR plus classic high load resistance training. All these things you have to by just understanding the flow chart and the previous knowledge, you can just apply into your practice. And in order to do a successful BFR clinic, then certain point you have to remember. Always see the contraindication. Whether you are contraindicated to exercise therapy, whether you are contraindicated to a what you call whether contraindication to because contraindication is identical to any kind of exercise therapy. BFR is also an exercise therapy. So if contraindication is there, avoid it. Kachu training either should not be provided, or expert advice should be obtained always when dealing with a hemodynamically unstable patient. If you are dealing with any kind of the hemodynamic unstable patient, don't do it. Otherwise, if at all under supervision, advice has to be there. Kachu training or BFR is a contraindication, or caution should be exercised when dealing with thrombotic patient. Thrombotic patient, it's always better to don't do it. If there is history of thrombosis, it's better to avoid. If there is a pregnancy with the problem of what you indicating of some antiphospholipid syndrome, antibody syndrome, don't do it. If there is the problem of post-COVID thrombotic condition is there, better don't do it. So all these things. Kachu training is contraindication in case of the thrombotic patient. Don't do it, or with caution you can do it. Explain if there's a petechial hemorrhage there. Sometimes it happens when starting the training. It's always better to explain to the patient or client. Otherwise, they will be very, very afraid. Then the apprehension may be there. So it's always better to explain that petechial hemorrhage may be there, numbness may be there. Explain about the petechial hemorrhage beneath the skin, and numbness may be there because of the blood flow. You have to explain that. And training has to be always individualized, tailored to the physical activity and condition of the particular person. That's why physical activity assessment is also very important. If you do any unaccustomed high intensity physical activity, rhabdomyolysis may be there. Any kind of the problem may be there. This thing one has to understand. So tailored to the individual physical activity, applied appropriate, as well as safe and effective pressure. You have to apply the effective pressure. Not too eager to gain. Never be too eager to gain result. It has always to be very slow, be very gradual. Never too eager, and avoid hemostasis with tourniquet, especially with the lower limb. Avoid hemostasis with tourniquet because of the higher probability of the what you call thrombosis, thrombotic risk. Build a relationship with the patient. You have to patient because of sometimes pain may be there, and petechial hemorrhage. You have to explain to the patient. There is a possibility that the pre-syncope and fainting will occur, may occur. but pay attention to the prodromal symptoms and take like fluid intake. This is important. What is happening is this pre-sync-up, fainting and sync-up may be happen especially in the starting phase, in the familiarization phase. Why? Because it may be because of the neurogenic, it may be because of the cardiovascular, cardiogenic or neurogenic. And that's why you have to explain prodromal symptoms. If there is any sweating and all this thing happening before the pre-sync-up condition is there, then you have to you have to have a close eye for that, and you have to take preventive measure like fluid intake and all this thing. You have to be very make sure that fainting may occur. That's why you have to have a good relationship with the your client or your patient. And for the older people, bedridden people, post-operative people who are having high risk for the vein thrombosis, so they often have venous thrombosis prior to training. So exercise cautiously. You have to be very careful. It's always better to avoid. And even if you have to do it, you have to be very careful. It has to be done with a very extreme caution. And ensure blood pressure is less than 160 or more than 95 millimeter mercury, depending upon this blood pressure. So blood pressure also, it should not be too high, it should not be too less. If the blood pressure is say more than 160 millimeter systolic blood pressure, if more than 95 to 99 or 100 millimeter mercury for diastolic, it's always better to avoid it, like we have already discussed. So you have to see a particular range of the blood pressure also during the exercise also. It's always, if some this what you call facilities is there to measure the monitor the blood pressures, do it. And the exercise, during exercise blood pressure also you can monitor, and you don't let it become very high. Also implement safety like AED, external automatic external defibrillator. You always have to be careful with the what you call uh, your emergency team ready, always train in the basic life-saving support, advanced BLS, ACLS, and all that stuff. Always train yourself. Always keep working AED. Always keep all the medicine which are required for advanced life support team. All these things important, because it can happen because of the higher sympathetic stimulation, ventricular fibrillation. Patient may go into ventricular fibrillation, suddenly myocardial cardiac arrest may happen. In that condition, AED is very useful. You don't have to waste even 1 second. Avoid conducting cardio training very long time. Avoid cardio training or BFR should not be done for a very long time. Like for example, upper limb you can do up to 10 to 15 minutes, lower limb 15 to 20 minutes. That's all. You don't prolong it, because if you prolong it, then hemostasis problem will be there. Then what will happen? There's always chance of the side effect, thrombosis. All this will happen. In principle, never conduct when the patient is sick. If the patient is sick, if there is acute inhales, don't do it. In principle, never continue performing cardio training when a case of patient feel bad during the training. If the person is feeling bad, then don't do it. Then don't force it. It is entirely up to his will, his choice. Don't force anything. When un, when unaware, if you are not unsure, if you are not sure about a patient medical condition, consult a physician, consult a specialist of that particular specialty, or go straight to the medical institute if you need to seek any other medical help, or just don't do it. If you are sure that something is wrong, some medical problem is there, but you don't know what is there, and you are not sure what is the condition of the patient, don't do it. Just don't do it. And if you have to do it, consult with a particular treating physician or a team of the physician, or a expert advice is always required. So in this way, if you perform your katsu training, if you perform your BFR training, then your the training or your exercise therapy, exercise procedure will be successful. And before ending the session, I would like to tell you something about the when to stop. Also, you have to understand when to stop also, because even if during exercise, if something goes wrong, then you have to understand when to stop. This is just a example. This is not the entire list. This is an example which will give you an approximate idea. Like for example, development of any significant ventricular or atrial arrhythmia, stop. Immediately stop. No second thought. Immediately stop. Make AED ready for any kind of the eventuality. So if there is an onset of the chest pain, chest discomfort, any other symptom suggesting of myocardial ischemia, stop. Dizziness, confusion, deteriorating balance or any other significant neurological symptoms, stop. If there is a paleness, if there is cyanosis or any other problem, stop it. Vomiting, nausea, feeling generally unwell, fatigue, all this, the pain, which you are not able to bear, which the patient is not able to bear, it's always better to stop. Decrease in systolic blood pressure from less than 10 millimeter mercury in the absence of symptoms. Even if as compared to the resting condition, systolic blood pressure decrease. See, remember, systolic blood pressure doesn't decrease in exercise. If systolic blood pressure decrease in exercise, that means something is wrong. Something is wrong. Diastolic blood pressure may decrease during exercise, especially during the isotonic exercise. So if there is increase in diastolic blood pressure more than say 10 to 15 millimeter of mercury, then something is wrong. If systolic blood pressure falls more than say 10 millimeter of mercury as compared to the resting level, then something is wrong. If from rest systolic blood pressure decreases by 10 millimeter of mercury, even in absence of symptoms, it's better to stop it, because systolic blood pressure doesn't decrease, because cardiac output is directly proportional to systolic. The determinant of systolic blood pressure is cardiac output. Cardiac output is the determinant of systolic blood pressure. So cardiac output will decrease because of the say cardio training. If you are doing cardio training, because of decrease in stroke volume, or it may be because of the fibrillation, because of the atrial ventricular fibrillation, or very high heart rate, the stroke volume may decrease, or it may be because of the cardiac output may decrease, because of the systolic blood pressure will decrease. Diastolic blood pressure main determinant is total peripheral resistance. So if total peripheral resistance is decreased, then diastolic blood pressure will decrease. If it is very, very high, if sympathetic stimulation is so high that total peripheral resistance becomes so high that your diastolic blood pressure becomes very, very high, that then also you can stop it. Like for example, if the systolic blood pressure, if the hypertensive systolic blood pressure equal to more than 250 millimeter of mercury, or diastolic blood pressure of equal to more than 115 millimeter of mercury, stop it. Don't do exercise. This is important. Exhaustion or fatigue, malaise may be there, sometimes persisting for days. It may be after exercise. That is out of the keeping with a person's usual response. Means if the fatigue may be there, which are persistent, then it's always better to stop the exercise. Or after previous exercise, although fatigue may lingers also, it may be there persistent for very, very days, and that is out of keeping with a person's usual response to exercise at a given intensity. At a particular given intensity, usually the person will have a particular fatigue. If the person is having more fatigue, which is unusual to his earlier experience, then also you have to be very, very careful. It's always better to stop that particular exercise, because he or she may be developing some other complication or some other problem. If there is swelling or shortness of the breath, then it's always better to stop. The skin of the affected limb is too hot or too cold to touch, and then it's always better to remove the what you call cuff and stop the exercise. Excessive pain is there in affected. Increase or excess, some amount of pain, tolerable pain, no problem, but excessive pain is there, then also it's better to stop. Excessive discoloration of the affected limb. Discoloration happens because of the ischemia, because of the compromise in the blood flow, the arterial compromised blood flow may be there. Because if venous outflow is too much restricted, then because of the increased backflow, because of the increased the pressure inside the muscle, and because of the contraction of the muscle, all these things, the perfusion pressure, arterial perfusion may not be there, and because of that, what we call ischemia may happen, and it may cause discoloration of the affected limb also. And also, like we have similar condition we have already seen in case of the surgical emergency, where a compartment syndrome, myocardial compartment syndrome, where because of the excessive pressure, limb catastrophic problem may happen. Limb saving surgery has to be done like this. And simply, if the patient requests to stop the exercise, stop it. So these are some of the common guidelines which I just want to share. And you have to modify depending upon your basic physiology and clinical knowledge and practical experience of the BFR for a successful running of the BFR, where you have to improve the benefit and reduce the risks. The optimization has to be done. This is important. So, thank you very much from my side. This is the end of the slide, and I want to thank all the listener for listening this relatively long talk. But all this point I want to focus, because ultimately what is important is you have to do the positive physiological adaptation, and this positive physiological adaptation is the one which will increase your performance, which will increase your fitness, which will increase your health. And just by utilizing the basic principle of the BFR, even you are able to utilize lower load with BFR, having the similar, similar or little bit higher physiological adaptation, then why not to go? Why not to go? Why not to? At least you can add on your BFR, low load BFR exercise in addition to the traditional exercise, high intensity exercise. So that is the key point. But for that, as we have already explained, you have to see your clinical reasoning, you have to see your whether contraindication or not, you have to see all the things, then only you will be able to successfully apply the BFR training. And BFR training, just like any other training, is just an interventional physiology. If you understand the physiology, if you understand the basic mechanism, if you understand the biochemistry, if you understand the basic clinical basic science, then everything is intervention. So BFR is just an example of interventional exercise physiology, interventional physiology. Thank you very much. Dr. Barun, signing out. Okay, bye. Thank you.